Thank you so much. Good morning, everybody. Today we welcome Dr. George Tharakan. She's a clinical hematologist who qualified first as a haematopathologist in 2014, completing an MMed thesis in 2016 from the University of Pretoria with distinction. That's really impressive. She's identifying a poorly resourced need within South Africa. She thereafter super specialized in clinical hematologist from Tygerburg Hospital in Cape Town in 2019. She worked with Albert Cellular Therapy from 2020 to 2025 while doing locum work for Pathcare. She has worked in various sites which included Pretoria East Hospital, Benoni, Glynwood, Witbank Hospital, and EPH, as well as Middleburg, Midmed. She has worked both in clinical role as well as a pathologist during this period. She joined Pathcare full-time in 2025, where she hopes to bridge the gap between laboratory and clinical medicine, providing diagnosis and critical advice to assist the patients in assessing appropriate hematological interventions in a timeous manner. Dr. Jim, thank you so much for presenting. She's presenting the topic Malignant Lymphoproliferative Neoplasms, when as a lump, not just a lump. Thank you so much.
Thank you so much, Michelle. Good morning, everybody, and thank you for this opportunity to do this presentation. So I'm talking about, and this is actually a follow-up from Dr. Perkowski's excellent presentation last week on an approach to reactive lymphadenopathy. I'm not going to dwell into the lymph nodes architecture or the pathophysiology because he did mention that in his last topic. So I won't go into the pathophysiology too much of lymphoproliferatives because this is quite a huge topic. Lymphomas in our WHO reference book is more than 100 types of lymphomas. So you can understand, I'm going to try and do a marathon through all the different types of lymphoproliferative, malignant lymphoproliferative conditions. So the incidence of lymphoma in the USA, that is the non-Hodgkin type, is about 77,000 per year. HIV, as we know, increases the risk of lymphoma. So globally, treatment advances have improved the outcome of lymphoma. In South Africa, though, it appears that the incidence is likely underestimated or underreported in the National Cancer Registry. So a study was done in 2019. It was published in one of the larger tertiary institutes in Gauteng, where the percentage of HIV-related lymphomas appears to be underestimated. So various factors were postulated, and one was the failure in the healthcare system in the diagnostic pathway. So that's why sessions like this is important, just to spread the word around as to what to look out for and when to refer the patient and when to biopsy the patient. The second thing that was identified as the coexistence of HIV. And this is because there's a lot of, HIV is a pandemic in South Africa. There's a lot of facilities available, treatment available, and patients are being monitored for the HIV itself and initiated on treatment appropriately and things like that. But the monitoring of subsequent secondary infections and lymphomas might be lacking. Also, there is an assumption, and we've seen it even to this day, where every lymph node is TB unless proven otherwise. This is not entirely wrong because we are in an endemic TB country, but also just to keep in your mind that, not all lumps are TB, and that's why follow-up is important in diagnosis. The baseline diagnosis is the most important thing, because a lot of the times I've seen patients being referred to me who've been treated as TB, but there was no diagnosis positive for TB. They've just been instituted on TB treatment, and then they come with all the side effects of the drugs as well as the lymphoma that you now have to address. Also, there's poor access to the healthcare centers for appropriate treatment. You will be surprised, South Africa is like a contrast in availability of healthcare. And even to this day, patients in a place you would think has ready access to a healthcare system, such as Pretoria, and I'm talking from personal experience where my helper struggled to get to a healthcare facility. She was She was very sick. She couldn't get up. There was no one around her in the location that she was staying at the settlement she was staying in. And she needed transport to go to a healthcare facility. She called the ambulance, and the ambulance couldn't come because there's no street number, there's no stand number, the roads are terrible. And also some of these areas, although in developed areas, they have a lot of violence and a lot of targeting of ambulance services. So some people have to go in there with police, accompanying them. So these are the kind of challenges that exist to this day, which is shocking. She was in Mamelodi, you know what I mean? Which you think is a reasonably good facility and settlement, and there is a healthcare facility nearby. So that was the problem. She tried Ubering, the Uber couldn't get to her because there was no one this. So that's just kind of highlighting where we are in South Africa. So there is also the lack of appropriate further lines of therapy, both in the government sector and in the private sectors. So I know when I was training in clinical hematology, we were limited with what we could offer the patients. We had chemotherapy, but there was chemoimmunotherapy. We were about 20 years behind with our treatment, at the time when I was training. Now, at least there is more accessibility, but still it's not ideal. And private sector, you have a medical aid, you pay for medical aid, but it doesn't mean that you will get the best. And that's a reality of the situation, because medical aids have stringent conditions with which you can get treatment. Chemotherapy, yes, it's easier, but chemoimmunotherapy and targeted therapy, which is where we are going globally, is not available. So lymphoproliferative neoplasms are due to the clonal expansion of lymphoid precursors or mature lymphoid cells. These are B cells, T cells, and NK cells. The majority of lymphomas arise from B lymphocytes, that is in 90% of the cases. Our WHO 5th edition classifies lymphomas by cell lineage, maturation stage, genetic drivers, and clinical behavior. Broadly, we have the acute and the chronic type of lymphomas, leukemias. We have the non-Hodgkin lymphoma, which is 90% of the cases, and Hodgkin lymphoma, which is 10% of the cases. Molecular profiling is mandatory for diagnosis, prognostication, and treatment selection. It's very important to have an integrated view using clinical, morphological, immunophenotypic, and genetic data. So as I said, I'm not going into the pathogenesis of lymphoma in this presentation, but you can see basically the lymph node, the maturation pattern, and where the different conditions sort of due to different mutational profiles develop. So we've got genetic and epigenetic drivers due to chromosomal translocations that cause activation of proto-oncogenes. They drive clonal evolution. They cause off-target somatic hypermutation, loss of tumor suppressors, and dysregulation, which sustains survival. And within the tumor microenvironment and signaling pathways, there are changes that occur that promote tumor evasion. And there's constitutive activation of certain pathways like the NF-kappa B in the activated B cell, diffuse large B cell lymphoma. So those are just the different mechanisms of tumor development. So I'm not going to focus too much, but I am going to mention the immature lymphoblastic lymphoma leukemias. This is the ALL. It's most common in childhood. 70–80% of pediatric leukemias are ALLs. There is a bimodal distribution in adults. The symptoms are usually acute, hence the name acute lymphoblastic lymphoma leukemia, and they present with bone marrow failure symptoms and signs like anemia, neutropenia, and thrombocytopenia. They also present with lymphadenopathy, organomegaly, sometimes with CNS involvement, mediastinal masses that cause superior vena cava syndrome. Morphologically, we have three different types of blasts. We've got this is based on the previous French, American, British classification. The L1 blasts are smaller blasts with uniform size, scanty cytoplasm, round nucleus, and small nucleolus. These are predominantly the childhood type of ALLs that look like this. Then we have the larger L2 blasts and the L3 blasts, which are seen more in adulthood. So this is the immunophenotypic profile that distinguishes between B and T cells. We've got different entities within the B cells. We've got pro-BALLs, common BALLs, pre-BALLs, and mature BALLs, as well as TALLs. And this distinguishing factors by the expression of the lineage-specific markers CD3 in T and CD19 in B. So treatment strategies involve chemotherapy and stem cell transplantation. Induction can be various depending on various regimens that are chosen. Basic regimen is a 4-drug regimen. Basically, we want a complete remission rate. We see that at 95% in pediatrics and 80 to 90% in adults. CNS prophylaxis is included in the regimen, and that involves intrathecal therapy. In some places, they use dual therapy. We use triple therapy, which is dexamethasone, methotrexate, cytarabine. Consolidation is with high-dose methotrexate, that's IVI, 6-mercaptopurine, cytarabine, and maintenance is for up to 2 to 3 years with daily 6-MP and weekly methotrexate. So this is important because there's a high relapse rate. Then we have the entity, which is the Philadelphia positive ALLs. These are responsive to TKIs, the tyrosine kinase inhibitors. You may have heard of the Philadelphia chromosome in association with the CML. It's just that the base point is different and the mutation region is different. And these patients have revolutionized their response based on the addition of the TKI, imatinib, dasatinib, and ponatinib including the chemotherapy regimen, and this is based on the GRAL protocol. Allogenic stem cell transplant is important and needed for high risk and also in relapse disease. There has been a marked improvement in the survival of patients in the AYA group. This is the adolescent young adult group, which is between the ages of 16 to 39. And this is because they've incorporated pediatric-based regimens in the chemotherapy, and these patients respond quite well. Additional targeted immunotherapies available are blinatumomab, CD22 targeted antibody-dependent cytotoxic antibodies, CAR T cells, venetoclax, navitoclax, and the most important thing post-therapy is MRD-guided de-escalation or intensification of response. And that is basically measuring minimal residual disease post-induction or post-therapy to make sure that you can de-escalate or intensify chemotherapy in time. So this is just briefly on the different molecular subtypes of ALL. We've got the pH positive, which is seen in adults. It usually conveys a poor prognosis until the integration of the TKI. Then we've got the pH-like ALL, the KNMT2A, MLL rearrangement ALLs. These are high-risk ALLs and is the most common. Then we've got a hyperdiploid ALL where we have more than 50 chromosomes, which generally confers a good prognosis, and the hypodiploid where there is less than 44 chromosomes, which gives a poor prognosis. Then we've got our TALL with mutations of the notch, TAL1, etc. And as I said before, minimal residual disease measurement by PCR and flow is the strongest prognostic factor that guides treatment escalation or de-escalation. Going to the mature lymphomas, we have the B, T, and NK cell lymphomas. So we're going to talk about the NHLs, and these are the common ones. These are the ones I'm going to speak about. There are others, as I mentioned before. So we've got the marginal zone lymphoma. So there are essentially 3 subtypes, which is the most common being the mucosal associated lymphoid tissue. That's the MALT cell lymphoma. It's gastric and it may be extranodal, but it generally is H. pylori driven with an excellent prognosis. Mutations like translocation 1118 can show that there will be a resistance to H. pylori eradication. Then these are the cells that you see on this peripheral smear. This is what it looks like. It's the treatment with gastric MALT lymphoma is H. pylori eradication and localized radiation therapy. Then we've got the second variant, which is the splenic marginal zone lymphoma, which is predominantly splenomegaly. So you target the spleen. There's very little peripheral lymphadenopathy, if at all. The treatment includes splenectomy, rituximab monotherapy, and if it is HCV-related, antiviral treatment. Nodal marginal zone lymphomas are treated, these are lymph node involvement predominantly. They're treated with R-CHOP regimen, which is a rituximab, cyclophosphamide, adriamycin, vincristine, prednisone, or the BR regimen, which is bendamustine and rituximab, and it generally presents in an indolent fashion. Then we've got the follicular lymphomas, which is the second most common NHL, with 25% of the cases. It's indolent in nature with a median survival of more than 15%. Morphologically, we've got a follicular architecture in the lymph node with centrocytes and centroblasts, and translocation 14-18 is what is associated with the follicular lymphoma. These lymphomas, generally grade 1 and 2, can have a watch and wait kind of a approach. And if needed, obinutuzumab, which is an anti-CD20 antibody in combination with chemotherapy. But once it progresses beyond the grade 3B, we have to treat it like a diffuse large B-cell lymphoma with more intensive chemotherapy. It may be associated with the EZH2 mutation, and there are EZH2 inhibitors, and the PI3K inhibitors can be used. The problem with follicular lymphoma is that it's very refractory in nature. It'll respond very well to chemotherapy and then come back. It's very irritating. But the problem with follicular lymphoma is also that it can transform to high-grade lymphomas, such as the diffuse large B-cell lymphoma. So generally, the approach to lymphomas, if we think it's like an indolent kind of a lymphoma, would be to use a CT. That would be the chest, abdomen, and pelvis would be advisable. And if we're thinking it's a higher grade lymphoma, due to the increased mitotic index and activity and aggressiveness of it, a PET CT scan is ideal. Now, patients who have a follicular lymphoma, over the years, maybe you have treated them, maybe you haven't, and you've been watching them, and there's sudden increase in the lymph node size, as well as B symptoms or compressive symptoms, and you need to restage them and you need to rebiopsy them, because you'll have certain lymph nodes which have follicular lymphoma and other certain particular lymph nodes that have diffuse large B-cell lymphoma. So in these cases, I think a PET CT scan would be helpful because it shows the avidity of the higher, more aggressive type of functioning lymph node, and you can biopsy from there. So that can direct your biopsy. Then we've got the mantle cell lymphoma, which is, you've got the classical leukemic and blastoid variants. It's generally aggressive. It's rare. Its median age of presentation in males it's predominantly in males, and it's in the 60s. It's associated with translocation 11-14, which causes cyclin D1 overexpression. There's a monotonous small medium lymphocyte infiltration, and it involves the mantle zone, and it's a diffuse infiltration in the lymph node. It's characterized by the expression of CD520, SOX11, and cyclin D1. It's negative for CD23. The blastoid or pleomorphic variants are high risk. They're associated with the TP53 mutation and have a high Ki67. Treatment is with R-CHOP, R-DHAP, and autologous stem cell transplantation. If the patient is not fit for this kind of a regimen, then you can give them the bendamustine rituximab combination, or BTKIs, which are easy to use. It's a tablet form, and you can use it as first line or second line. And we've got a first generation, second, and third generation available. Also, venetoclax, which is a BCL2 inhibitor, combinations can be used. Now, CLL or SLL, which is basically the lymphoma variant of the CLL, is the most common in the Western world. We do have an entity called the monoclonal B-cell lymphocytosis, where the absolute lymphocyte count is less than 5, but it's persistent. It may express CLL-like phenotype, but it's generally indolent. You just have to monitor the patient because they can progress to a CLL at a later stage. So the diagnosis of the CLL is based on a persistent lymphocytosis of greater than 5 times 10 to the power 9 of clonal B cells. They express CD5, 19, and they're 23 positive. The mantle cell lymphoma is 23 negative. And then they're CD22 dim. So morphologically, as you can see, typical CLL cells would be the ones on the top. They are small, mature lymphocytes, and you can have smudge cells, which is basically like you can see sort of nuclear material without much else. And that kind of warns you that there's a high proliferation and breakdown of these cells. And you can't identify the source of it, but we assume in this case that it might be lymphocytes. Then what you need to monitor for are these larger cells, right? Like at the bottom where you've got a slightly larger cell, you've got a more dispersed chromatin pattern and prominent nucleoli, and these are pro-lymphocytes. Depending on the number that you can get, that you count, you can get pro-lymphocytic leukemia, which is one of the known transformation entities of the CLL. Now, CLL, what is very important is to check the genetics of the CLL, because the CLL can behave in different ways depending on what genetic abnormalities are present. You've got the IGHB mutated variant, which is a favorable prognosis. But if it is unmutated, it confers a more aggressive prognosis. And then you have to monitor this patient closely for transformation and progression. And you probably need to initiate treatment at an earlier stage. The other thing you need to monitor for is the deletion 17p or the TP53 mutation, which confers a high risk behavior. Intermediate risk behavior is seen with deletion 11q, and 13q is a favorable kind of behavior. So we use the Ryan-Benet staging system for classifying the CLL. This is based on the number of lymph nodes, lymph node sites that are involved, and the bulk of the lymph node size, as well as the cytopenias, resultant cytopenias. And that will warn us of when to initiate treatment. So it's generally a watch and wait approach with CLLs, but there are key factors that you need to monitor for when you're seeing your patients, you're following them up. There's a rapid lymphocyte doubling time within 3 to 6 months where it doubles, as well as B symptoms. You can check biochemically, a rise in LDH, evidence of tumor lysis perhaps, but mostly the B symptoms, splenomegaly that's getting bigger, lymph nodes that are enlarging. These are all time points when you need to consider transformation or progression, and then you would need to marrow the patient at this time. You can do a staging bone marrow for CLL, but that will tell you what the IGHB mutation is, and that doesn't change. However, at the point when you think there's progression, you would need to marrow the patient, because if they did not have a deletion 17p or a TP53 mutation at onset, at that point of progression, they may have it, and that would mean that we'd have to treat them with different agents. So generally treatment is with venetoclax and obinutuzumab in the fit patients. You have also the BTKI inhibitors. In the unfit patients, we are steering away from traditional chemoimmunotherapy in these cases, but that is what has been used in the past. Okay, then we go to the more aggressive phenotypes, and that is the DLBCL, diffuse large B-cell lymphomas. It's the most common NHL. It's about 30 to 40% of the cases. They're aggressive with a median age of onset of 64, but this has changed. I've seen younger patients with diffuse large B-cell lymphomas. It involves nodal and extranodal sites. They are classified according to the cell of origin, and based on the lymph node maturation, they can be germinal center or activated B-cell. And this is kind of prognostic in the way they behave. We have entities which are very important, and that is based on the Hans algorithm. We use the double hit lymphomas, where they express the IA in immunohistochemistry. On the biopsy, they may have the MYC positivity. We have to do FISH for MYC, BCL2 and 6, and that'll tell us if they're double hit or high-grade B-cell lymphomas. And then we have the entity of the triple hit, where all three of them are positive, and this is the worst prognosis. Generally, these patients are considered like high-grade B-cell lymphomas and treated entirely separately from the diffuse large B-cell variant. That's why it's very important to distinguish between the two. Also, we have these double expressor lymphomas, which have in immunohistochemistry, they have the MYC, and then they have either BCL2 or BCL6, also conferring a poorer prognosis. We have this a lot in our HIV positive population as well. So morphologically, they're large cells, vesicular nuclei, prominent nucleoli, diffuse lymph node growth pattern. They express CD19, 20, and PAX5. The MYC is there, as well as BCL2. That's that double expressor phenotype. But the Chi67 is usually around about the level of 80. But with the higher grade ones, we see it at a higher Chi67, which is the proliferative index that we use to measure on our lymphoma patients. Treatment. R-CHOP is a traditional treatment, and they do relatively well with that. We have polatuzumab. We have dose-adjusted R-EPOCH for the more aggressive variants, and they have to go to an autologous stem cell transplant as soon as possible. And we also have, in relapse refractory cases, we have the CAR T cells now that are being used. Then the most aggressive is the Burkitt lymphoma. If you remember from the pictures I showed you between the L1 and the L3 blasts, these are the L3 blasts. You can see they're bigger, they're medium-sized, dispersed nuclear chromatin, prominent nucleoli with vacuolation and deeply basophilic cytoplasm. These also have like this starry sky kind of an appearance if you go into the lymph node, and I'll show you a picture of that just now. So these are an emergency situation. A Burkitt lymphoma is an emergency. It's the most aggressive NHL. Its doubling time is within 24 to 48 hours. It's an emergency situation. You have to monitor for chemolysis syndrome. Patients can deteriorate. You need to hydrate them. They need to do a chemolysis prevention protocol, and they need to go and get treatment immediately. There are 3 variants. We've got the endemic, the African type, which involves predominantly the jaw and facial bones. It's EBV positive. We've got the sporadic, which can involve the ileocecal region. EBV positivity seen in 30%, and then we have the immunodeficiency associated one, which is the HIV. They are characterized by MYC translocations, that's translocation 814, 28, 822, and immunohistochemistry, we see CD10-20 co-expressing cells, BCL6. They don't usually have BCL2 and TDT. The Chi67 is 100%. I've told you about the proliferative index. From 40 in the indolent, 30 to 40 in the indolent type, to 80 in the diffuse large B-cell type, this is 100%. So you can see how aggressive its activity is. So I've talked about the rapid workup and prophylaxis, tumor-lysis prophylaxis. Treatment is with intense chemotherapy. It's DA-EPOCH, R-DA-EPOCH based, Codox MIVAC, hyper-CVAC. Those are intense. They need to be admitted. They need to be monitored. So children usually has an excellent cure rate. With adult, outcomes are variable, 60 to 70%. Long-term survival. CNS prophylaxis is mandatory because of the sanctuary sites. We need to give them triple intrathecal therapy and high-dose methotrexate, which is included in that Codex MIVAC. It's one of the components of it. So I talked about the starry sky appearance. This is literally what the starry sky appearance. It's not projecting that well, but you can see that monotonous blue kind of background of these Burkitt cells, and in between you get these tingeable macrophages, which are basically soaking up all the waste products and all the debris from those cells' activity, and you can see it's similar to a surface. Okay, now the mature T cells and NK cell lymphomas. The peripheral T cell lymphoma, not otherwise specified, is the most common. It's pleomorphic, medium-sized cells with inflammatory cells and vascular proliferation in between. Immunohistochemistry, it's CD3 positive, which is lineage specific. But there is also a loss of pan-T markers such as 5 and 7. It may or may not express CD30. Molecularly, it has a TBX21 and GATA3, and treatment is with CHOP or with a CHOEP, which includes the CHOP side. The 5-year overall survival rate is about 32%, and we usually consolidate in first remission with a stem cell transplant. The angioimmunoblastic T cell lymphoma is also known as the nodular T follicular helper cell lymphoma angioimmunoblastic type. It's an EBV-driven B-cell expansion. It's characterized by general lymphadenopathy and hepatosplenomegaly with B symptoms, skin rash, and a polyclonal hypergammaglobulin. There is an expanded follicular dendritic cell meshwork with prominent high endothelial venules and EBV-positive blasts, and this is in node. Mutations associated with it are the TET2, DNMT3A, IDH2, and they express CD10, BCL6, CXCL13, and PD1. Treatment is with the CHOP regimen, as well as cyclosporine or azacitidine, especially if they're TET2 positive, and an acidin, which is a IDH2 inhibitor. Overall survival is about 30 to 40, with relapses occurring. Auto stem cell transplant is the next step, especially if they were chemosensitive because of the relapse rate. Then we've got our anaplastic large cell lymphoma. They're characterized by CD30 expression. Morphologically, they have this typical horseshoe-shaped nucleus. They can be ALK positive, which generally confers a better prognosis and is seen in younger patients with a 5-year overall survival rate of 80%. ALK negative entities are seen in older patients with heterogeneous kind of behavior, and if they express TP63, it's a very good prognosis. So that's where the genetics come in. Also, with patients who've had previous breast implants, I've actually had a patient like this who has had a previous breast implant, and then you get this kind of a ALCL developing. In her case, she had removed the implantation, and generally that gives an excellent prognosis. In her case, she needed chemotherapy, but she responded extremely. Immunohistochemistry, we have CD30 positivity, ALK positivity, and treatment is with the CHOP regimen with or without etoposide. We give brentuximab vedotin, and we kind of we give them the cyclophosphamide, the adriamycin, and the prednisone, and especially if they CD30 positive. And so they have really good prognosis from that point of view. So if they have relapsed refractory disease, then they are transplant eligible. We need to try and get them to transplant. Then the next one is the cutaneous T-cell lymphomas. I will be talking about the mycosis fungoides and Sézary, which is just the systemic variation of it. These are what morphologically the cells look like. The mycosis fungoides is common. It's a primary cutaneous T-NHL. And clinically, they present with patches, plaques, tumor, erythroderma, and histologically, they have the Potrier microabscesses. Morphology, they're small to medium in size with cerebriform nuclei. And there's epidermal tropism without spongiosis. And they express CD3 and 4 and 5 may be positive, but they're characterized by CD7 negativity. They can be staged as 1A to 2A, where it's just predominantly skin involvement, and 2B, 4 to 4, which is advanced disease. Skin-directed therapy is the main modality of treatment with topical steroids, Pruva, and UBT. In advanced stage disease, we need to give them histone acetylase inhibitors like vorinostat, but mogamulizumab is also very good for these patients if they are refractory, and bendamustine vedotin, brentuximab vedotin, and allostem cell transplant if they don't respond. So the Sézary syndrome is basically the leukemic phase, and be characterized by erythroderma, circulating Sézary cells, and lymphadenopathy. Similar to what I've mentioned before, they are characterized by clonal T-cell rearrangements. They may need extracorporeal photopheresis, that is the ECP, and the CCRX4 antibody, which is superior to vorinostat. These patients, in as much as we say this, I've had one lady who had severe skin involvement. She had nodal disease at some point. She was treated topically with the skin-directed therapy, and she responded for some time. Then she, on follow-up, developed nodal disease, and that's when we got involved, where we had to give her chemotherapeutic agents. And she developed side effects to that, and then she responded at some point with the skin, and the nodes all disappeared, but then the skin kept coming, and it's quite extensive, and it's quite debilitating from an emotional, psychological, and physical point of view. It really affected her life. She barely goes out, she barely socializes, she doesn't even want to come to see the doctor. That's how it has affected her, I tried motivating for mogamulizumab. That one, I struggled so much, and they just weren't bringing it into the country because it was too expensive. So that's kind of challenging, and she had medical aid. Okay, the next entity we have is the aggressive EBV-driven NKT lymphomas. These are seen in Asian, Latin American populations. It involves the nasal cavity, nasopharynx, palate, which can causes midline destruction. It's angioinvasive, and there's necrosis. Morphologically, we've talked about the angiocentric, angiodestructive infiltrates, these coagulated necrosis with a mixed inflammatory picture. They express T-cell markers 2, cytoplasmic 3, and NK markers 56, and they are EBV positive. They are associated with DDX3 mutations, STAT and TP53 and JAK-STAT mutations. There is localized disease and can be staged as 1 and 2. And we use a non-anthracycline regimen, which is the SMILE regimen, which is dexamethasone, methotrexate, ifosfamide, L-aspartate, and etoposide. Or the DDGTP, which is more intense. It's the carboplatin, gemtuzumab, as well as radiation therapy. So disseminated disease needs the GEMOX or the SMILE approach, and they generally have a poor prognosis, and an allotransplant is what is advised in a relapse case. And pembrolizumab is a PD-1 L1 inhibitor, which can be used. Then we go to the chronic NKT cell lymphomas. This is TLGL, the large granular lymphocytes. It's a chronic proliferation of cytotoxic T cells. It's indolent in behavior, and generally patients present with neutropenia or anemia, rheumatoid arthritis in 25 to 30% of cases, and splenomegaly. Morphologically, you can see typically those lymphocytes with the granules within them. These granules may contain perforinogranulin B. They express CD3, 8, and they can express 57 and 16. And TCR alpha beta more than TCR gamma delta. Treatment is with methotrexate, cyclosporin, cyclophosphamide, and GCSF for neutropenia. I've had a patient who I put on chemotherapy, and he was just persistently neutropenic, and we needed to support him with GCSF. That's something that we just never could change. The problem with LGL, TLGL is that it's generally okay, but then when you get the NK LGL, this is cases where they're CD3 negative and CD56 positive, they're rapidly fatal and very aggressive. So that's why we need to monitor these patients and just regularly follow up with the molecular testing as well. We then have the hepatosplenic T-cell lymphomas, which is rare, aggressive. It's generally seen in young males. A sinusoidal infiltration of the liver, spleen, and bone marrow. It's characterized by CD3, 56 TCR gamma delta positivity. There's no lymphadenopathy, and it's associated with immunosuppression. So patients who are post-solid organ transplant, irritable bowel syndrome patients who have been on thiopurines, this is an association with it. It's a monotonous, medium-sized lymphocyte. In the hepatic sinusoids, the red pulp with minimal portal involvement. Treatment is with intensive chemotherapy with ICE, IVAC, or hypo-CVAD regimens, with allostem cell transplant being the only curative option. So it's a very extremely poor overall survival rate with early relapse despite the aggressive treatment. Then we have our ATLL, which is the adult T-cell lymphoma leukemia. It's HTLV driven, endemic in Japan, Caribbean, West Africa, South America. If you're writing in KZN, this is like compound. Anyway, 1 to 5% carriers of HTLV develop ATLL after latency of up to 40 to 60 years. The subtypes are acute, which is aggressive, the lymphomatous, and chronic small. Morphology is typical flower-shaped cells. You can see the nuclear pattern is in the multilobated flower cells. Immunohistochemistry shows CD4 and 25 and FOXP3 positivity. They are characterized by CCR4 mutations, as well as TP53 and JAK-STAT mutations. They can be treated with zidovudin and interferon alpha and CHOP-based regimens. Mogamulizumab is actually ideal for these kind of patients as well, especially in infectious disease, and allostem cell transplantation. So the prognosis is for the acute is poor, especially despite the aggressive therapy. So we talked about non-Hodgkin's, and that was just 90%, and it's not even 90% of the different types of non-Hodgkin's. Now we'll just go briefly into Hodgkin lymphoma. We've got our classical, and we've got our nodular lymphocyte predominant lymphoma. Classical is composed of nodular sclerosing, mixed cellularity, lymphocyte depleted, and lymphocyte rich. Classical Hodgkin lymphoma is characterized by the typical Reed-Sternberg cells, such a beautiful cell over there. It's within 100% of the cells, maybe 1%, you will see the Reed-Sternberg cells, right? They're basically crippled germinal center B cells that have lost their B cell identity. They weakly express PAX5. Immunohistochemistry, they're typically expressing CD15-30 co-expressing cells. They're CD20 negative, and EBV LMP1 is positive in 32% of cases, and that is in the mixed cellularity. for case. So they come with B symptoms in 30% of the cases. That's a fever greater than 30 centigrade degrees Celsius, drenching night sweats, more than 10% weight loss over a 6-month period, unintentional. They are staged with the Ann Arbor staging system, and then the nodular lymphocyte predominant LP cells are known as popcorn cells, and that's what you see at the bottom. If you have a good imagination, you don't need such a good imagination. You can imagine that's a popcorn. Anyway, tomorrow is popcorn day, by the way, in South Africa. We celebrate it as popcorn day. We are celebrating popcorn day tomorrow. So just for FYI. Okay, anyway, so these are the popcorn cells. They're characterized, though, with CD20 positivity. So these patients, you treat them differently. With the classical Hodgkin's, you treat them with a different regimen. With the NLPHL cell variant, you treat them with the R-CHOP, and they do extremely well. Problem is the medical aids don't always see that. Because it's called Hodgkin's, they expect ABVD, for example. All right, so treatment, early favorable disease, you give ABVD ×2 and radiation therapy. And we use PET-CT scan is considered the gold standard in monitoring progression and response to treatment in Hodgkin's lymphoma. So the unfavorable subtype, we give ABVD ×4, radiation, or we give BV-ABD, where we omit bleomycin and all its pulmonary side effects. In advanced cases, we give them an escalated BIACOP or BV-ABD treatment, which is based on an echelon trial. The PET-CT scan guided de-escalation is done at interim and at end of treatment, or if you're suspecting progression or poor response. Relapse refractory cases, we have to give them salvage treatment with IgEB, GDP, DHAP, and an autologous stem cell transplant. We've had patients where we've given 2 autologous stem cell transplants, 10. Then we can give brentuximab vedotin, which is that VB component, excellent response when they respond. And we can give them also as maintenance to prevent relapse disease, and that's based on that Thera trial. We've got PD-1 inhibitors, which can be used in relapse refractory cases. Take-home messages. Okay, I'm not going to, these are just targeted therapies. We're not going to go into that. I'll go into a better version of this slide. So an approach to diagnosis. What's important? What's your take-home message? It's lymphadenopathy or suspicious masses. You have to be aware of them. Patients may say, oh no, there's this mass that was there for the longest time and suddenly is grown. Those are kind of indications for you that this needs urgent biopsy. So we prefer cervical sites, depending on the surgeon, of course, and axillary is then the next option, and inguinal less so, because as Tommy's presentation last week, it's very reactive with inguinal region. We want a core biopsy or an excision biopsy. No FNA, you're wasting your time, your patient's time, and the trauma and the stress that goes with it. Please, we need an excisional biopsy or a core biopsy. By chance, they have a substantial lymphocytosis, and that is where it's important for us to do an FVC and ask for a differential. If they have a substantial lymphocytosis, we could make a diagnosis on peripheral blood flow. It's non-invasive, it is expensive, but it gets you the answer. Diagnosis and staging involves imaging. As I said, the indolent lymphomas, CT scan, chest, abdomen, pelvis is ideal. FDG, PET-CT scan is the metabolic screening tool, and it's usually if you're suspecting a high-grade aggressive type of lymphoma. Histologically, we need the histology for morphology as well as genetics and molecular differentiation. Bone marrow examination with cytogenetics and molecular tests is part of the staging. But don't be surprised if you don't get a positive involvement in the bone marrow. Lymphomas don't always involve the bone marrow. And that's where sometimes doctors refer patients to us for a bone marrow before doing a lymph node biopsy, and yet there was a lymph node. So that's a frustration because that's where you're going to get your diagnostic yield. But we still have to do it as part of the staging because that will tell us if there is bone marrow involvement in the outset. With treatment, has that bone marrow involvement disappeared? Okay, restaging is performed if treatment is curative. If it is a non-curative kind of, like I told you, a follicular lymphoma patient, they responded and they came back, yes, you have to biopsy them. But then if they've been on treatment and they're relatively stable, you don't have to necessarily restage them all the time unless there's an indication for it. Non-FBC blood tests that you can do that will guide you or give you clues, because this is not definitive, is an elevated LDH. Advanced stage lymphoma, aggressive disease is a high LDH, but you know more than me the causes of raised LDH other than lymphomas. And then elevated creatinine and uric acid with an acute onset, no other explanation. And I had an interesting case where I think I might have mentioned on this forum before, where there was just a persistent renal failure. It's a non-hypertensive, well controlled, no issues with that. He's got a CLL monitored for months, no acute issues. But this persistent renal failure. Send him to the nephrologist, they did a biopsy, and it was CLL. So, I mean, that patient needs treatment. Where he was on a watch and wait kind of an approach, he then needs treatment. So those are the kind of things you need to keep an eye out for. Elevated ESR is not specific, but it can give you a clue. Elevated liver canalicular enzymes, as I said, it is liver involvement. Coombs positivity with low haptoglobin, raised reticulocyte counts can be associated with the hemolytic anemia. You know, lymphomas can be associated with hemolytic anemias. So those are just clues that you can use. And obviously the B symptoms that we've talked about, the lymph nodes that are involved, the size of the lymph node, the texture of the lymph node, it's painless. Sometimes it's not necessarily acute onset, kind of a thing. This is not projecting well, but I found an interesting article by one of my senior colleagues from Cape Town, where she differentiated the lymphomas kind of as an approach to low grade or indolent, high grade or aggressive, and very high grade or very aggressive. This is just sort of like a framework on what the cell of origin is, demographics, the subtypes that we encounter, the risks if they are undiagnosed and untreated, and diagnostic urgency. So it's a nice table, I thought. And then the treatment of the different grades of lymphomas is just sort of like a overview of all the different treatment regimens available. Yeah, that's it. Thank you very much.
Feel like I actually need a certificate for a crack. Yeah. Look, well done. This is just showing that your confidence in the topic, and you're always knowing what you're doing. So it's amazing. So the question that I just wish to register is actually that internal medicine should actually have this overview, because I think when we're in university, you always have to plan your own way to try to understand it. And it's become very extremely difficult because you have to be reading and you look at Harrison's just so much you get bored when you see this CD4 and all those, even you don't know what CD4 stands for. It's kind of crazy, but I think obviously you simplify it so easily and it's so lovely. Well done. Eh? This is quite a really good presentations, and I think we need to market it very well with the fellow students and everything. I think because we cannot deal with this on a daily basis, and if you are pulmonologist or physician or hematologist or whatever you are, you will come through lymph nodes, and I mean, obviously, when you do general examination, the first thing always whether you're a surgeon, you look at the lymph nodes, and when you have it, then you need to understand what actually, what to look for, because then you always need to make diagnosis. So I think for me, that was amazing. 2 weeks ago, we have a patient that actually have a chronic right lung mass that she been worked up, and she was very confident that's not a cancer. We thought it was aspirations, and she didn't really want to have surgery because she got hiatus hernias that went bad, and she refused. So we had to do a CT-guided biopsy and actually come out as marginal lymph node, marginal lymphoma of the right lung, which was my first in my career. And obviously, we have sent Dr. Britton, and I think bone marrow was not really helpful. And we have seen most of those in the GIT tract, but then gastroscopy was normal. The question, how do you treat them? Do you resect them? Because it was lucky that she ended with us, so we didn't really send her for resection, but rather send her for So we send her for oncology, Dr. Britton. So I think in terms of pulmonology, you always have to kind of, when you have what look like organizing pneumonia, you might need to biopsy. It's very important because you never know what come out of it. Yeah. So I think we see those within the pulmonary context. Yeah. And Ian, you see a lot of those, obviously.
Yeah, I mean, I see a lot, and I think as a general physician, depending on how you rotate it, like I never rotated through hematology, and my knowledge is very limited on all of this. So it's good to just, you think you know something, meanwhile you never think, Oh wow, yeah.
Yeah.
Anybody
It's
online?
overwhelming. The drugs are completely overwhelming
Yeah.
to me. Yeah.
Who's RG?
Rashana.
Anybody online? Questions? Hello? Okoli? Are you awake?
Yeah, good morning, everyone, and thanks for the great presentation. No questions from my side.
Cornell, are you there? Yeah, but it's a good presentation, to be honest. It's really something that I think just give it that kind of refreshing. And I would like also to listen to podcasts, hopefully when I take my long drive, because we now have really a lot of podcasts. That's the beauty about it. And practice medicine become extremely easy because you're having so many of them that your mind just goes around. And I always remember great professor like Professor Kerr. When you look at their knowledge, it's just amazing that they know all these corners, but I think because of that's have a bit of everything in life. So I think for me, knowledge is just power. You need knowledge because at the end of the day, patients need a solution to their problems. And you cannot limit yourself just to one field of medicine. I think the more you know, the better you can help, and the more you can be precise on your diagnosis. I think we move into the era where precision medicine become the key, than hunting all over the place. So you need to be precise in the way how you actually think, how you diagnose, how you reach the solutions in. So thank you so much. This was amazing.
Thank you.
And we appreciate it.
Thank you.
Yeah. Okay, do you have a wrap?
Yeah.
Yeah.